Recording. So this video I've titled Preliminary Steps in Radiography. On my computer I titled it What to Do Before You Do What You Do. And it's really better said what to do before, during, and after what you do. So these are things to consider for your exam before, during, and after, before you release the patient. So the reason I recorded this one, wanted to record this one, was to take care of some of the housekeeping that is common to all exam types. So I'm going to talk about all of those things in this particular video, but I'm also going to touch on them probably in some other videos as well. Also, though, what you're going to see is that there are elements from the video How to Be Successful in Your Clinical Education course. So some of this will be a repeat of that, but it bears repeating. And instead of covering these things as Merrill's does in every chapter on every projection, I'm going to cover it one time, then I'm going to touch on it where I need to. So preliminary steps in radiography, where I got the mainly the images were from Merrill's Atlas of Radiographic Positioning, Von Traeger's textbook of radiographic positioning. I didn't pull anything out of the Martinson book because there was nothing unique in that. So primarily Merrill's and Von Traeger's is where I got this. So your room setup, the things that you need to consider for your room setup is what type of room are you working in. So there are a lot of different types of x-ray rooms. Even within a specific type of x-ray room, there are different exams that you may see in each one of those rooms. So what type of room are you working in? Are you working in a radiography room, or are you working in what we refer to as an RF room, which is radiography and fluoroscopy? So what type of room are you working in? You're probably not going to need things like barium in your radiography rooms. You're just not going to do a whole lot of barium exams, but you may need, if you do a high volume of trauma in some of those rooms, you may need some things like cystographing. I've worked in trauma rooms that we did a fair number of cystograms for ruptured bladders. So consider your room type. If you're in a radiography room that neither one of those two things applies, then you're probably not going to need either one of those. So what type of patients also will you have? Are you working in a outpatient type setting? Some of your hospitals have set aside specific rooms for outpatients. Or are you going to see a lot of inpatients? Are you going to see a lot of ER patients? Are you going to see inpatients who are going to need contrast exams? So a lot of things to consider in your room type. And let that drive what your preparation for the room is. But what you always need to do is make sure that your room is clean. At the start of every working day, you need to get in the habit of cleaning your room. That's rubbing everything down. I'm not going to say that the people on the shift before you might have not done their job, but night crews tend to run a skeleton crew, and sometimes they don't get around to cleaning things up as well as what you would like for them to. So before your first patient comes in, the first thing that you need to do is clean your room up. Wipe everything down. If you're in an RF room, wipe down the control handles for the fluoro tower. If you're just in a diagnostic room, make sure you wipe the tube down, make sure you wipe the control panel down, certainly wipe the bed down, wipe down the wall bucky, everything that you might touch during the day. And then stock it with the supplies that you need. Going back to the room type, what supplies do you specifically need? What equipment might you need? So do you need like maybe tabletop grids, tape-on grids, snap-on grids, those sort of things. Then anticipate your what kind of patients you're going to have. Most of your hospitals are going to have some sort of common place where they have all of the scheduled patients listed, so that you can take a look and see what you probably are going to have in your room during that day if you're in an RF room. So if you happen to see something that's a little bit off, an exam type that you don't normally do, it's not completely weird. You've got equipment for it, then go ahead and have that on hand so that you don't have to scramble and go look for it later on. So keep your room clean. And in your room, what you want to do is make sure that you've got plenty of trash bags. So you got a lot of different types of trash bags. You got the true trash bags, but you've also got the linen bags. Make sure you got plenty of those. Biohazard bags if you need those. Make sure that your sharps container isn't so full that you can't fit more needles or scalpels or whatever it is that you might happen to be using that day into the sharps container. Make sure that you got sani wipes. Those are just so easy to pull a sani wipe off and sanitize the handles and the touch surfaces that you're going to use. Wipe down the x-ray tube, all the portions of the x-ray tube that might have come in contact with the patient or your hands or whatever. Make sure that you keep that clean. Wipe down the tabletop, the pad the patient's going to lay on. Make sure that you've got clean linens on the table on top of that pad and on the pillow, fresh pillowcase. And make sure that you got towels, wash rags, all of that sort of stuff in the room. Regardless of whether you're in an RF room or just a radiography room, certain things that you're going to need would include things like towels, wash rags, any of your linen sheets, pillowcases, possibly emesis basins. Personally, my personal opinion on emesis basins is that trash cans are so much better. And in that context, make sure that you have plenty of trash bags. Emesis basins are those little kidney bean shaped things that if the patient gets sick and they throw up in, they have a hard time keeping it all inside that emesis basin. A trash bag is so much better, or a trash can with a trash can liner in it. So keep it stocked throughout the day. If you use something, you use a stack of linens, go ahead and replace those. Replace them with fresh and clean linens so that you can continue to draw from those. If you're in a fluoroscopy room, make sure that you've got contrast in trays. We're going to talk about gowns, sheets, pillowcases, towels, wash rags, and emesis basins, so we'll skip through that. Also, if you happen to be working in a facility that has a CR system instead of a DR system, you may have some differences in image receptors and image receptor sizes. So I'm going to just kind of touch on this, and then we're going to look at the different types of image receptors. I've got in red the type of image receptors you just don't see all that much anymore. They're not digital image receptors. They're either screens and films, which really nobody in the United States should be using. And then you've got your CR system, cassettes, and then you've got your digital system. So in the cassettes with films and in the CR systems, you may have multiple image receptor sizes. With a DR system, you're going to make an exposure. Your system is going to clear that exposure, and you're going to be ready to make another exposure. With your photostimulable phosphor plates in CR systems, you can only put one exposure on that plate. So you're going to make an exposure, and then you've got to put it into a reader that'll lift that information off that plate and then give you the plate back. So you may have multiple sizes. You may have a 14 by 17, you may have a 10 by 12, you may have 11 by 14, you may have 8 by 10. So again, in the room type that you're in, make sure that you've got ample image receptors if that is an issue. If you're working off of a digital image receptor, most of the time, most of the ones I've seen are square. So they're 16 by 16 or 17 by 17 or something like that. They're quite large, and you only have one size. So that's not really an issue unless you're working off of a CR system. So image receptor and field size considerations, and this is part of what I was talking about and not wanting to have to cover this on every projection. So there are basic rules for image size and field size considerations. First off, the image receptor size that you should use should fit the part. So if you're doing a pediatric chest x-ray, there's no reason to use a 14 by 17 image receptor. There are times that might be appropriate if you're in a stat situation where you're up on a patient's floor and the only thing that you have is a 14 by 17 and time is of the essence. Don't leave the patient, go get a smaller image receptor. to make the exposure. Just use beam restriction and collimate down to the patient's size. So that's a general rule. Image receptor size to fit the part or fit the patient. You want to use the smallest image receptor size that will work, and then you want to collimate to the part. So regardless of the image receptor size that you use, you want to collimate to the anatomy of interest, and you want to use the smallest field size without excluding anatomy or clipping anatomy and not including it on the image. And your field size should never be larger than the image receptor size. You're not going to record anything that's outside of the image receptor size anyway. So if you're not going to record it, the only thing that you're adding is patient dose if your field size is larger than your image receptor size. Now, there's one other consideration, and that is that sometimes you may need an image receptor size that's actually a little bit larger than your anatomy size. So because we create x-rays, and x-rays come from a point source on the anode, and they spread out isotropically, but we limit the beam to an area beam, then what we have then is a beam that's kind of pyramidical in shape, so that the center of the central ray, and that's what we're referring to in the central ray, is the very middle of the x-ray beam is the central ray, should be perpendicular to the middle of the anatomy. But whatever is outside of that gets an angulation with a central ray. So by the time you get to long anatomy, like let's say a tib fib, which is your lower leg, or an arm, your forearm, then the angulation in the periphery is pretty significant. So you may need an image receptor that's slightly larger than the anatomy. So image receptor to fit the part, with the caveat that you may need it a little bit bigger than the part to compensate for that divergent central ray. So there is also an orientation consideration as well. So if you have a image receptor that is not square, like a 14 by 17 image receptor, then you need to consider its orientation as well. And you've got to know the patient's body habitus to understand how to put that image receptor best to work best for that patient's body shape and their I just said the word habitus, body habitus. So if you have a patient who is hyposthenic, then what you're going to have is a patient who's got very long lungs. Their lungs go from, it seems like, top of their head to their kneecaps. So if you've got a rectangular shaped image receptor, then what you're going to want is that image receptor to be loaded lengthwise. So it's a 14 by 17, then you want the 17 measurement going with the patient's, the length of the body. If you have a hypersthenic patient, most of the time their lungs are going to be very broad, but they're going to be short. So what you're going to want is that image receptor crosswise to capture the breadth of the patient's lungs. So image size orientation needs to be considered as well. If just looking at this, we can look at a couple of other things. If we're looking at the patient's shoulder, the evaluation criteria for shoulder is to include everything from the proximal portion of the humerus down to the bottom of the shoulder blade and all the way over to the medial end of the clavicle. So entire scapula, entire shoulder girdle, all the way over here. But this distance is longer than this distance, and therefore we would need a 10 by 12 crosswise for a shoulder. So consider the anatomy, and whenever you're reading through your Merrills or your Bontrager's and you're seeing the image receptor sizes, take note of that, make a mental note of that, so that you can use that in positioning if you happen to be working with image receptors that are rectangular. My mouse is so sensitive, I'm having a hard time here. All right, so this is a CR imaging plate. So what is inside of this is a photostimulable phosphor, but it's got some elements to it that hold on to some of that image capture. So when you make an exposure on this, it glows. I posted a couple of videos in the physics thing where I took some X-rays on some old X-ray film cassettes to demonstrate the glow. Well, these will glow as well, but these hold on to some of that glow, so they don't release it all the way. So you make the exposure, you take this thing, you stick it into a reader, and the reader lifts whatever is still stored on that plate, and it makes the image off of that. So these plates were used, this is actually the back side of the plate, but these plates were used on the back side of the cassette. They were used kind of in our first generation DR. So as computer reconstruction of the image, but the equipment looked a lot like film. So screen film cassettes looked a lot like this, and it was a lot cheaper to go with CR before you went with DR. Once a hospital went with DR, then the image receptors were hardwired into the computer system. I'm not going to say they can't be removed. They can, but it was much more of a commitment than whenever they went with CR first. With CR first, the only thing they had to do is swap these out for cassettes, screen film cassettes, and then add a reader. So they eliminated the processor. The processor became the reader, and this was almost identical to screen film. So it was an easy transition. But what you're looking at now are these things, solid state digital detectors that are hardwired into your system so that you make an exposure on this thing and it sends a signal directly over to the computer to recreate the image. Same thing with this. You've got tethered, you've got untethered. Some of your DR cassettes have contacts that whenever you put it into either the wall bucky or the table bucky, those contacts prepare the reader and start the communication process so that as soon as you make an exposure, again, it articulates directly with your computer to recreate the image. But this is an oblong image receptor. This thing is massive. I would say that's probably close to 20 inches, probably like an 18 by 20 inch image receptor size. I've never worked with one that big. And this is just another one of wireless digital image receptor. So your fluoroscope, traditional fluoroscopy, this big apparatus here is actually the image receptor. So this entire thing is an image receptor. The X-ray tube is inside of the table. So this is an RF room because we've also got a X-ray tube here. So we can do both. We can do fluoroscopy and also radiography as well. So with this being the image receptor, everything that we're shooting with the patient flat on their back is a reverse of what you're used to seeing. So with the patient laying flat on their back, it would be a PA projection. Some of your newer systems have the image receptor below the patient and the X-ray tube above the patient. So this is also digital fluoroscopy, but it's just a different orientation with the X-ray tube above the patient. So when you prepare your patient, the first thing that you want to do is introduce yourself professionally. Call out the patient's name. Once the patient stands up, introduce yourself. Tell them who you are, what department you're with, and tell them that you're going to take an image. I hear a lot of people saying, well, we're going to take a picture of your shoulder. We're going to take a picture of your knee. We're going to take a picture of this, that, or the other thing. And to me, that just cheapens the whole process. You're a medical imaging professional. You're creating a medical image. Yeah, it's, fundamentally it's a picture, but it's not the same as a picture that the patient would be getting at Sears Portrait Studio. So really professional communication with your patient is we need to take an x-ray, we need to take an image, and not we're going to take a picture of. Okay, so introduce yourself, tell the patient what you're going to do, but check the armband. Sometimes you walk into the waiting room and you call out a name, Mr. Smith, and you get three people, one of which is a woman, that stand up. And the patients are just nervous and they're anxious and they're not listening very closely. And so whenever you call out a name, they're just ready to go. So it's important not just to call out the name, but also check the armband to make sure that you got the right patient. Explain the exam to them, ask pertinent questions. How did you hurt your knee? Does it hurt to walk? Does it hurt to bend? Where is the pain specifically, so that you can pass that information on to the radiologist. So take a thorough history, but don't record the entire history. The radiologist doesn't really need to know all of the bloody details of how the patient hurt themselves. What they need to know is where is the pain and potentially what was the mechanism of the pain. So keep that in mind. Don't give them a novel to read. Just tell them where the pain is. Patient fell, left knee pain, something like that. Patellar pain, something like that. So take thorough history, record that for the radiologist. Observe for potential issues like clothing artifacts. Our image receptors now are so sensitive that they will pick up almost anything. So make sure that it's really best to go ahead and dress the patient. Have the patient take off whatever clothing that they're going to be wearing, or whatever clothing that they wore into the X-ray suite, and put them in a gown. Make sure that you have the gown available for them immediately. I've seen patients just start coming out of clothes before you even have a gown out. So make sure that you have it immediately available. But that kind of eliminates potentials for artifacts. So if you're not real familiar with what an artifact is something that shows up on the image that shouldn't be there. For example, older ladies are, if you have an older lady for a chest x-ray or an abdomen x-ray and she is in a gown from the house that she wore from the house, it's not a gown from the house, I would say there's a better than 50% chance that there is a safety pin in that gown somewhere. That's my experience. They just have a safety pin. They want to tighten it up and make it a custom fit, and they have a safety pin somewhere in it. They've forgotten that there's a safety pin in it, and they'll tell you there's no safety pin in it, but whenever you make your image and you show it to the patient, they say, oh yeah, I forgot all about that. So it's best to just go ahead and put them in a hospital gown rather than to run into any of that. But consider also the patient's ability to perform. If you bring a patient to the x-ray department in a wheelchair, you might want to take a look and see if they have any legs before you ask the patient if they can get onto the x-ray table. But also consider, just in observation, take a look at the patient. If you have a patient who's kyphotic means that they're kind of hunched over and they're older, then there's a very good chance that they got multiple compression fractures in their spine, which would be painful for them to lay flat on their back on the x-ray table. They might not be able to lay flat on their back on the x-ray table at all. So you may have to have supports in place for them in order to take a flat KUB or an abdominal x-ray on them. Or conversely, you might consider doing the patient upright. So consider the patient's ability to perform and adjust to that if at all possible. Adjust your expectations according to what the patient can do. So after meeting the patient, consider their abilities, their ability to follow instructions. Are they older? Can they hear? Are they potentially senile? If they're there with a family member, you might make some eye contact with a family member and try to assess whether or not the patient can really participate the way you would want them to. Consider their illness, their pathology, their injury. What is the likelihood that they will be able to get up on the x-ray table and do the things that you will need them to do, or will you need to compensate for the patient? Also, the pathologies that we potentially may be looking at, you read your request and you see something like pleural effusion, and what you're doing is chest x-ray, and the patient can't stand up because they're so sick. So you might want to check with the doctor and offer the doctor some options in order to visualize that pleural effusion. if you take a pleural effusion, if you're unaware of what that is it's fluid inside the thoracic cavity, but it's outside of the lung, inside the pleural space, so it's free to move. And how we diagnose a pleural effusion is with a horizontal x-ray beam. And what we do is we roll the patient onto their side and we shoot with an x-ray beam that's horizontal so that we can see, and this is going to be a bad example because there's a dip in the cup, but we can see exactly where the fluid level is, as opposed to if we're looking straight down onto the patient's anatomy, we wouldn't be able to make that out. So consider the pathology, the injury, the illness, the patient's ability to cooperate and participate in those contexts. We touched on patient comfort before, and certainly we want to consider patient safety. The last thing that we want to do is have the patient leave in a worse condition than whenever we brought them. So make sure you consider the patient's safety. Put the side rails up if they get off of or if they're on a stretcher. Lock the wheelchair. Don't put them on a rolling stool if you think that the stool might get out from under them. So more things to consider, patient position and projection. So position refers to the patient's body position. Is the patient upright? Is the patient laying down? Is the patient somewhere in between? What we refer to as semi-Fowler's position. If the patient can stand upright, what projection are we going to take? So projection refers to the path of the x-ray beam. So if we shoot with a projection where the x-ray beam hits the front of the patient first and exits out the back of the patient, that's what we call an anterior-posterior projection. So if we want to get the patient upright for a chest x-ray and shoot a posterior-anterior projection, because that puts the heart closer to the image receptor and it reduces magnification of the heart. And if it reduces magnification of the heart, we're less likely to make a diagnosis that the patient has an enlarged heart. So we want to shoot with PA projection, but can the patient really perform that? The patient can sit up, but the patient can't stand up. So chances are you're going to have to do an anterior-posterior projection. So again, consider that as well. Don't be so set in your mind what needs to happen according to the textbook that you miss what has to happen according to the patient's condition. So consider what equipment to use: wall bucky versus tabletop. Can the equipment be modified? Like let's say the patient, you want to do a chest x-ray on the patient and the patient can't stand up, so you're going to do AP, right? Can the wheelchair be accommodated to fit to the wall bucky? Can the back come off? Can the arms come off so that you can just wheel the patient back to it and put the back up against the image receptor and make your x-ray? So can the equipment be modified for patient comfort? Rather than moving the patient over onto a stool, can we adjust the wheelchair and keep the patient there? So always keep patient safety in mind. Image receptor size and orientation we already talked about. We're not going to do it again. So your distance rules, you've got two main distances. One is your source to image receptor distance. So generally we use two. One is 40 inches and one is 72 inches. And there's certainly metric centimeter equivalent to that, but for the most part, every hospital I've ever worked in used inches, so we're going to stick with inches. So source to image receptor distance is generally going to be 40 inches to 72 inches. Object image receptor distances are going to vary according to a lot of different things. So what we want is I'm going to refer to source to image receptor distance as SID, source to image distance. So SID, we want an SID that's adequate. Not all SIDs need to be at very long distances. Our OID can and does affect greatly how much magnification we have. So if we can't get our anatomy close to the image receptor and reduce our OID, that's object to image receptor distance, then what we may need to do is compensate with an increase in SID. So what we're seeing here is a difference in lateral chest x-rays, one done at 40 inches, and what we see with a 40-inch is quite a bit of magnification. The lung field looks much larger than what it does on the opposite. So I don't know for sure that these are the same patients. You got to assume that they are. I think these came out of Bontrager. You got to assume that they are. Whether or not they truly are, I don't know. But the lesson here is that the shorter the SID, the more magnification you have. At the same time, the greater the OID, the more magnification you're going to have. So if you can increase your SID to 72 inches, it reduces some of that magnification. Also, again, if you have an unavoidable increase in OID, you can increase SID to offset that. Like whenever we do lateral C-spines, neck, then we have to put the image receptor. It would seem like we could put it right here, but we can't for reasons that we'll talk about when we eventually get there. But we'll put the image receptor out at the shoulder. With it out at the shoulder, if we're looking for our neck, then our object to image receptor distance is quite great. So we're going to have to increase our SID to 72 inches. Most things we shoot at 40 inches. There are things we have to shoot at 72 inches because of an increase in OID. So radiation exposure and protection is a big part of our job. It's probably become more a part of our job in a digital world than what it was before. It's always been a very important portion of our job. But because some of the image formation portions of our job have become more dependent on the computer, what we focus now on is more radiation exposure and protection. As a matter of fact, the ARRT exam, the American Registry of Radiologic Technologists board exam, the radiation exposure and protection portion has increased in size quite a bit. It used to be 30 questions, and I think it may be close to double that now. So it's a very important part of the registry that you need to make sure that you're prepared for. So technical factors, making sure that you use the proper KVP and mass. And really in a world where we've got automatic exposure control that sets our mass, the important thing there is making sure that we have adequate KVP. Make sure that your KVP is adequately high. The higher the KVP and the lower the mass, the lower the patient dose. Double check the exam. What you see on your request and what you see in the patient may not be the same thing. So it bears some checking and making sure that that the orders weren't put in improperly. I've seen situations where a left hip was ordered and the patient's issue was with right hip. And if that wasn't caught in taking a history on the patient, asking the patient where they hurt, then that patient could have received a left hip x-ray and gone completely without a diagnosis of a right hip fracture and sent home in pain. So double check the exam. Does the history fit? Is the patient complaining of pain in the extremity that was ordered for the exam? So take your history, apply that, observe for signs and symptoms. Make sure that you use beam restriction. So remember back from Bouchong's chapter 1, Rollins developed beam restriction for the sole purpose of cutting back on radiation to the patient, and it still applies. Shielding still applies for you as a technologist. You have to wear your lead apron. But there's a lot of, and the reason I put this in parentheses with a question mark, is because there's a lot of controversy, I won't say controversy, debate whether or not shielding should be used. And I think that the industry standard is going more towards not using shielding. So make sure that you follow your hospital protocols on that. So you've got radiation protection for the patient, and that's what we just talked about. Fellow co-workers, it's important to make sure that they're protected as well. So if you're working in a trauma room and somebody doesn't have an apron on, you got to make sure you call out x-ray before you make your exposure so that you just don't go blasting people with radiation. But also you need to take care of yourself as well. So what we see here in this graphic is a number of different things. So you've got presumably a radiologist. Radiologist has a thyroid shield on, a apron on. This is an apron, very thick apron across the front of across the the end, I guess, of the fluoro tower. So this will be the image receptor. So the x-ray beam is coming up under the patient. This is a pediatric patient. So I get the tendency of the technologist here at the end of the table to kind of mother this patient and say, "Ooh, baby, I'm so sorry you're going through this." Comfort the patient. But the only radiation protection that this technologist has going for her is the apron. So she's leaning out over the table. She's getting an eye dose. She's getting thyroid dose, assuming that she doesn't have a thyroid shield on. So her dose is much higher than the radiologist. So maybe that needs to happen with pediatric patients to keep them from squirming all over the place. But if you get in the habit of doing this with all of your patients, you're taking a radiation dose that you just don't need to be taking. So make sure that you follow the cardinal rules of radiation exposure, and limiting radiation exposure for the patient is to keep the dose as low as reasonably achievable. We'll refer to that as ALARA, but make sure that you also take care of yourself, and your dose reduction is time, distance, and shielding. So the least time she spends right here absorbing all that dose, and the patient really is the source of our dose. The x-ray beams coming up through the patient, interacting with the patient. She's getting scattered radiation off the patient. So spend as little time here as possible. So that's time. Increase the distance as much as possible. So get away from the patient as far as you can, reasonably, without freaking the patient out. Back up away from the patient as far as you can, reasonably. Increase distance, and also wear your apron. So time, distance, and shielding is radiation protection for the radiographer and the radiologist. So remember, the x-ray beam comes out of the x-ray tube in isotropic emissions. The central ray should be perpendicular to the anatomy of interest, but the peripheral x-ray beam is kind of like you've taken and you've angled your central ray. So you can tell a lot of stuff about how x-rays behave in a darkened room with a flashlight. So let's say we've got this water bottle, right? So if we've got this water bottle and our flashlight is shining directly down onto the water bottle, the shadow of the water bottle is going to look just like the water bottle, right? But if I move it off to the side just a little bit, then what you're going to start to see is the side of the water bottle, because the central ray is angled. So the peripheral portion of the central ray is going to carry with it an angulation that's going to distort the image and potentially project anatomy off of the image receptor. So consider your technical factors. If you have a patient who can't cooperate well, maybe you've got a Parkinson's patient who, some of your Parkinson's patients have tremors and they can't be still. So how we can affect that is with a number of different things. Most common thing is increase MA and decrease time, and that would limit motion. You can also throw KVP in there. If you increase your KVP, you can reduce your overall mass and thereby reduce your time as well. So consider your technical factors. Make sure that you give the patient good instructions. Make sure that you give them good instructions on how to dress and what to remove so that you limit your artifacts, but also your motion artifact. And I think that's what I was going with there. Give them good instructions so that you can limit the motion artifact. So if you're doing a chest x-ray on the patient, you're looking for the lungs. You don't want the patient to breathe. So what you're going to do is you're going to have the patient inhale, exhale, inhale, and hold their breath. So on that second inhalation, you get a better inhalation of the lungs, and you have the patient hold their breath so that it limits motion artifact. So good instructions. So when to rotor would be dependent on really what it is you're doing. So if I'm doing a chest x-ray, then what I'm going to be doing is I'm going to be positioning the patient. I'm going to be with the patient at the wall bucket. I'm going to tell them to take in a big deep breath. And I'm going to make my final adjustments with the patient to make sure that they didn't breathe themselves off the image receptor. So I'm going to make that final adjustment. I'm going to tell them blow their breath out. And I'm going to put my hand on their back and I'm going to say, okay, take in another big deep breath. And as they're slowly taking that breath in, I'm walking around to the control panel, I'm rotoring up, and then I say, hold your breath. They hold their breath. I make the exposure, release the button, tell the patient to breathe. It seems pretty obvious. Tell the patient to breathe. Don't take anything for granted. So make your exposure after the patient's perfectly still, after you've made final eye contact to make sure the patient didn't move. I've had patients, as soon as I took my hand off of them for a chest x-ray and went around to the control panel, as soon as I took my hand off of them, they turned around and followed me around to the control panel. So look at your patient before you make your exposure. You rotor up, you make your exposure, but before you make your exposure, make sure you get eye contact with the patient and make sure that something hasn't happened that requires you to reposition the patient. So this is kind of what I was talking about with divergence of the central ray. If we're taking an x-ray of a knee, then we need to be centered on the knee. If we're taking a picture, or there we go. If we're taking an image, an x-ray of the knee, and we center mid-femur, then look at the angulation that's coming off on the knee. This is a picture. That's not an x-ray. Then we're going to get distortion of the knee, and that's just not good. So assess the image after it pops up onto your computer. Certain things have to be on every single image. So patient identification, institution identification. So the patient identification may be their name. It may be a number, but one of those two things needs to be present. In every hospital I've ever worked in, both of them were a part of the patient identification that went on the image. So patient name, patient number, the date of the exam, the institution, and some of your hospitals will use date of birth as well. So that would be 5 different things most of your hospitals, or most of the hospitals I've worked in, used. The reason they use so many different markers was because it's the more you have, the harder it is to mistake a patient. So if you have a patient named John Smith, or even better than that, if you have a bad trauma night and you have a John Doe, and you name everybody in that comes in John Doe, then at the end of the night you can't tell them apart. So you have to have something else. John Doe 1, John Doe 2, John Doe 3, and then it makes it a little bit harder to make mistakes between the patient. But a very common thing that you see in a ward in a hospital is a placard on a door that says name alert. So you go up to the patient's floor to do a portable chest x-ray on the patient. You push your machine up to a door and it says name alert. That means that the name that you probably have on your request matches the name on the door, but there's another person by that same name on that floor. So what you need to do is you need to look at those other markers to make sure you don't take an x-ray on the wrong patient. So patient identification, side marker. Side marker is what we are referring to in this thing right here. So this indicates that this was done with the patient's right side against the image receptor, which is different from what you're going to do on almost every one. This is lateral chest x-ray. Lateral chest x-ray is a side view. And most of the time we're going to do a left lateral chest x-ray, but this is a right lateral. So this indicates that this was done with the right side up against the image receptor. So most of your hospitals are also going to require not just that you've got a marker, an L for left or R for right, but also one that has your initials on it so that if there's something going on with the patient, they can come back to you and they can say, okay, what's going on with this patient? What do you remember about this patient? So side markers. Anatomy. Is it visualized? Did you include all of the anatomy that you need to see? Full disclosure, you can't always do that. Sometimes a femur, for example, won't fit on an image receptor. So you may have to take 2 images of the femur in order to get a kind of a composite view of what the femur should look like. But in most cases, you can get all the anatomy on there. Is it visualized? Is it not only is it inside the collimated field and on the image receptor, but are the radiographic quality measurements, are they adequate to demonstrate what you want to see? Is contrast there? Is the density there? Is it distorted, indicating that you got either off-centering or an angulation on the central ray, or possibly the patient, their anatomy is not parallel with the image receptor and perpendicular to the central ray? So was beam restriction utilized? Beam restriction is collimation. So beam restriction and collimation, the way that works is it's a little bit confusing. As you increase collimation, that means you decrease field size. So 3 different things tied up there. Beam restriction and collimation mean the same thing. Field size really means the same thing. But as you increase collimation, you decrease field size. So increase collimation means to make the field size smaller. So was it utilized and was it adequate? There are some tools on a digital imaging system that you can use to make it kind of look like you used collimation. Really recommend you not use those tools. If you failed to use beam restriction, well, you just didn't do your job well. There's just no covering it up. You just didn't do your job well. So learn from that and not do it again. The problem with the tools that make up for lack of collimation is, one, they don't make up for lack of collimation. Patients still receive that dose, but the biggest problem is if you included anatomy and then it's what we call shuttering, and you shutter off some of the anatomy that you included, then what's to say that the patient doesn't have a pathology that they didn't know about in that anatomy that you shuttered off? So it needs to be included in the image that's sent to the radiologist. Test your beam restriction. So your exposure index number is just a number that whenever you make your exposure, every exposure that you make, you're going to have an exposure index number. And it's a clue as to whether or not you use the right quantity and quality of radiation. It's not the definitive clue, but it is a clue. So what does your index number look like? Do you have adequate collimation? If you don't have adequate collimation, your index number may indicate that you overexpose the patient. So it's a measure, but not the measure. So presence of motion, is it there? What might I be able to do to get rid of the motion, make a better image? Presence of noise being fog, and we'll talk about fog later in the semester. But also things like quantum model. Quantum model is kind of a speckly appearance on the image because you didn't use enough radiation. And finally, finish the paperwork and dismiss the patient. Turn in all the information to the radiologist so that they can make a diagnosis on the patient. So then you come to a point of when to repeat. So there are times to repeat, and there are times to learn from your mistakes. Take your lumps and not repeat. So when to repeat, things like if you have poor positioning where you have missing anatomy that could determine whether or not the patient, whether or not the image is going to be diagnostic. So if anatomy is missing that's pertinent to the exam, then you need to repeat the exam. If you have distortion that could interfere with the diagnosis, again, you need to repeat. If joint spaces need to be open and they're closed, then you need to repeat. If you have superimposition of anatomy that needs to be desuperimposed, then you probably need to shoot a repeat. Superimposition just means a stacking of one thing on top of another. And then if you have artifacts covering up the anatomy, these are external artifacts. You also have internal artifacts that you can't do anything with. So if a patient has a pacemaker, you're not going to cut the patient open and take the pacemaker out. That's an artifact that you can't do anything about, but it is an artifact. But if the patient, for example, has telemetry, heart monitor on, they usually put a heart monitor in a harness that just hangs around their neck. So you're taking a chest x-ray on a patient, you've got this thing sitting in the middle of their chest that's like that. That could potentially interfere with a diagnosis. So you don't necessarily need to take the heart monitor off of the patient because it's got the leads that are plugging into the patient in different places. But what you can do is take it and just drop it down in front of the patient and then lower it down in front of the patient. And what that'll do is it'll take all those leads, all those lines, and it will pull them tight straight out in front of the patient. So you have less superimposition of those artifacts. So you can do something about them. Is motion present? If motion was present, you probably need to repeat. If you have gross over or underexposure that causes a loss of contrast or density, you probably need to repeat. So anything else that might interfere with a diagnosis, you need to repeat the image. There's only one in diagnosis, by the way. When not to repeat, if you failed to collimate, you failed to use beam restriction, and you go back in to repeat that exam, remember what the purpose for collimation is, and that's to reduce patient exposure. So if you fail to collimate and then you go back in and you collimate the image, you make a second image on the patient with the same anatomy, then you more than double expose the patient just to kind of cover up your mistake. So wrong exposure factors that don't interfere with the diagnosis. So things like if you use too high of a KVP, which there's evidence that you almost can't do that now within a reasonable range. If you use too high of a KVP, then no. If your index number indicates that you overexpose the patient just a little bit, then no. Because again, you're going to go back in, you're going to make another exposure on the patient, and again, you're going to more than double the patient's dose. So a small amount of increase, overexposure on the patient, the computer system can compensate for that. Gross underexposure, it cannot. So again, you would need to repeat an exposure for gross underexposure. So just learn from your mistakes and do better the next time. Don't go back in and make a situation worse by repeating something that does not necessarily need to be repeated. So final thoughts, reassess your patient after you see the images. Did you see something that might require follow-up? Like, did you see that pleural effusion? Did you see a collapsed lung? Collapsed lung, the definition of a collapsed lung is atelectasis, but pneumothorax is evidence that we've got a collapsed lung. So do you see a lung and then you see an air pocket that has no lung markings at all? That's a pretty good indication the patient has pneumothorax. Do you see dislocations or separations, or do you suspect separations where the order may have called for suspicion of dislocations. For example, two different shoulder injuries that sound like they are the same thing, and they're greatly different. So a dislocated shoulder requires that the ball comes out of the socket joint, and it's usually anterior dislocation. It pops out anterior and falls down inferior. That's a dislocated shoulder, as opposed to a separated shoulder is where the clavicle and the scapula meet at what we call the acromioclavicular joint. So separated shoulder involves the tearing or at least the spraining of the ligaments that hold those two things together. So you get a patient back for a shoulder dislocation, and you make an exposure, and there's no evidence this patient has shoulder dislocation. You ask them where the pain is, and they point directly to their AC joint. That may be an indication you need to go back to the ER doc and say, hey doc, this patient's complaining of pain right at the AC joint. Do you want me to go ahead and take an X-ray of him, just to make sure? So we have different protocols for those two different exams, dislocations versus separations. So do the patient's symptoms align with what you see? Maybe the wrong exam was ordered. And it's good patient care to follow up on that and ask. If you get a hand for a right, or a request for a right hand, and the patient's clearly complaining of left hand pain, that's worth investigating. It very well may be that what they're doing, especially in pediatric patients, is doing a comparison view between the two to see if the epiphyseal plates are intact or if there's some sort of potential fracture through those. So there's a legitimate reason sometimes to do the opposite extremity, but it's worth investigating. If you have no context as to why you're shooting the opposite, then ask. Sometimes your ER docs may get a little impatient with you, thinking that you're questioning what it is that they're doing, when in fact you're exercising good patient care. So don't be afraid of the ER doctors. Your primary concern is for the patient, not for the ER doctors. So any red flags noticed in an interaction with the patient, like anatomy is more unstable than it should be. And I mentioned here what we refer to as a Masseneau fracture. So a Masseneau fracture is a very specific fracture. Clinically, it's a fracture of the ankle, but there are no broken bones. So what you have with your lower leg is you got the big bone, the tibia, and the fibula being the small bone, and it's got this tissue wrapped around it, and it's what we refer to as a syndesmosis, and it keeps the bones kind of secure. Think of it as kind of like a compression sock. With a Masseneau fracture, what happens is maybe the patient twists their ankle, but what happens is all that ligamentous fascial tissue rips from the ankle all the way up to the knee, and it pops out right at the fibular head, and that's where the fracture is. So the most unstable fractures of the ankle that I've ever seen in my life were Masseneau fractures. So the patient's complaining of pain in their ankle. You go in, you pull the covers back, and maybe they've got bruising all the way up to the knee. And you go and you pick up the patient's foot and their ankle to put it on your image receptor, and immediately the foot dislocates. You can see it, you can feel it, and you can hear it. It just goes ka-thunk whenever you pick it up. Set it back down, and then go maybe talk to the ER doc and say, hey, doc, can I just go ahead and shoot an AP of the leg? I think this patient may have something else going on. So if you just blindly follow what the order calls for in that case, you're going to miss the fracture of proximal tibia, or fibula rather. So ask. Certainly you can't just go blasting the patient. You're going to have to ask, consult with the doctor before you dismiss the patient on any of those things. So that's the end of this particular video. I hope to get a video out on chest x-ray, AP and PA chest x-ray, sometime this week and actually start into that. I meant, again, my intention was to start summer, through the summer, start with that, and things have changed. Some things beyond my control. So what I'm intended to do was to just go with ARRT content. I think in the previous video I said ASRT, but it's ARRT content specifications. And I think I want to expand that just a little bit to be more comprehensive. So what I'm going to do is I'm going to do chest x-ray, AP and PA chest x-ray in the first video. And I'm going to go through both Bontrager's and Merrill's and the Martinson book, and I'm going to talk about not just positioning, but also correction for mispositioning as well. So thank you very much for all your support. I thank you for your time and watching. And if you have not subscribed, please do so. If you have or have not, please hit the thumbs up button. It just helps to get these videos on the page in more circulation and reach more people. Thank you very much.